Okay, there we are. Can you hear me? But now I've got to get my video, start video. Okay. Yeah. It's like a moment of panic there, hey? Yeah, thanks. Can you hear me on the speaker? Can you hear me?
Yeah, we can hear you, Karen. Can anybody else indicate that we can hear her?
We can hear her.
Ah, great.
Can I share my screen?
No, we're going to start with a few slides. That's us.
Mm-hmm.
So we're going to have a few slides just to introduce you,
Mm-hmm.
which is always nice. And then you're going to start. Is that okay with you, Karen?
I'm just hoping it works. That's all. That's fine.
Well, you know, we are very, what's the word? We're very normal here. And if it doesn't work, then we just try again. I think
it should be
that's
fine.
the guy for you. We sometimes have strange things happening to us, and then we just carry on. So, as you know, we always, that's the nice thing of starting a bit later with a few of our slides, Karen, is that we actually, people sort of slowly start trickling in the first 5 or 10 minutes. So then they get to the meat of your talk at the right moment. So I think we will start. So I'll start to just say hello to everybody this afternoon. It's great to have you at our second session of the year. Dr. Karen Günther is going to speak today, but let me just start with the housekeeping notes. We can find the recordings at the website, and then the CPD points, as I said last time, will be automatically submitted. And please, if it doesn't work and you don't get anything back that you need, let us know, because then we can iron out those problems. And Melanie Davids is the person responsible for that. So, and then the next slide. Okay, so what we did today, we actually did a little survey, and we only had feedback from 44 of the many people who attend, but let's hope it was representative. So we can see that there are 3/4, well, just under 3/4 of state doctors or personnel attending. And then, so mostly in the hematological sector, which is probably the ones who fill in would be the most, you know, hematology oriented. But we often have other attendees from other disciplines or areas. And then interestingly to me, that 2/3 are not in training anymore, and that a good 30% are training in hematology, and even a few in another field. Who's next? Then we will not change the format, because people seem to like the reminder on a Friday and the kind of a heads up, and then continuing on the Monday to just let us know we must get there. So interestingly, the top 5 sessions of the year, I do think that the number 1, which was our wonderful speaker from Canada, it was a fantastic talk, I agree, but I think he kind of got a kind of a, you know, sort of a head start over the others. If we had flipped the whole chart, I wouldn't be surprised if he had more competition. But the wonderful thing is that the other 5 talks are all from different centers, totally different centers. This one talk is actually from our colleagues from Sifaku Makhato, who actually presented for the first time. So that is wonderful. And it just shows that this is a place where we learn and speak about stuff that we don't always get the chance. So the autoimmune hemolytic anemia was really a fantastic session, and all these other sessions from different parts of our country, north, south, east, west. So I think so. That's the feedback. We also asked a few other things about what would people like to see, and they were actually the things we had expected them to ask. So I'm not going to share that. So today, Dr. Karen Gunther needs no introduction. She always lifts the academic level of any meeting by about 50%. She asks the type of questions that either intimidate or inspire, and it's only the first time, I think, perhaps that, or on an off day, and that's the whole point of Deep Dive, Karen, is that here we learn not to be intimidated. Here we just learn to be ourselves. And I must say, I've listened to you sometimes and thought, why did I not think of that? Where's that question coming from? But it's just so important and so incredibly wonderful to have a totally different group of people with each with certain strengths. And your strength certainly is very much the academics. I see cum laude was your degree from Cape Town, which takes something. And then you went up to the north, and then your master's was actually done on, if I remember correctly, it was on TTP, isn't it? Your MEd, yeah.
On PCR, actually.
Oh, I see.
It was the start of using PCR in hematology.
Oh, wonderful. Okay, so many different publications, and so numerous articles in local and international journals. And she is very, very active and has done something amazing in her practice. And yeah, one day we must speak about starting a transplant center in from scratch in this country, and that's what you've been doing. And then patient care, that's your first love. So the heme team of Olivedale is famous, and we are so thankful you're there. And thank you that you take a time out of your very busy life, your very busy and varied life, because you do find time for running, for family, for horses and mountain bikes. So thank you. And without more ado, please, let's hear Ash in a Flash with some practical tips I've heard. So
let's see if I can share my screen.
Perfect.
Sorry, we're almost there. All right.
That's great.
So,
yeah.
Firstly, just thank you for that very kind introduction. Wow, that's a bit hard to live up to, speak out. But, I was thinking as I was preparing for this, deep dive is so appropriately named, because it should be a deep dive into academics and all that, but into the things that help us in the end to treat patients better, even from the baseline and research and laboratory. It's all about trying to help your patients. And it's just been awesome over the years to just see what a huge difference things have made. It was such a privilege to go to ASH. I loved being there on the ground, being able to ask questions. And, even if you take time off, if you're doing an online meeting, you just don't get stuck in. I came home with a whole book of information. And honestly, in the first week, I was referring to it the whole time. And I'll highlight at the end, stuff I've put into practice. So it's not all we heard the amazing thing last week about the bispecifics and all the stuff that's happening, but there's stuff you can learn on the ground and these sort of things. So that's what this is about. It really is a whistle stop to it, as Andrew and Jacques did one small section each, and I'm trying to cover a massive amount. So apologies, it's going to be quite short and sharp. I thought I'd concentrate on myeloma a little bit because I think we see so much of it and there's some really good stuff out there. But most importantly, at first, I have to tell you about New Orleans. So the Mississippi is huge. You don't realize it. Beautiful. And it is, New Orleans is just an assault on the senses. It's music, it smells, it's loud, and the food is phenomenal. And there's this place called Bourbon Street. Did you know that there is, all these are different kinds of bourbons? And did you know that Jacques Malherbe is an expert and he knows about all of these and could pick out the ones he still needed to taste. So new sights on colleagues. Eh? And there's Jacques, he was a great dinner companion. We had incredible food. New Orleans is famous for the food. And one of the one thing I did, actually, I honestly went to this meeting because it was just like a shot in the arm. It was so exciting, but I went to see the slave plantations. This is the one where they filmed Gone with the Wind and 12 Years a Slave and all that. And but the one I went to, what they actually have done is got all the information about the slaves, and they've set up a memorial to them. There's a memorial park, and then these walls and walls of these little things about the name of every single slave and what they were paid for. And then under some of them, there's these little absolutely heartbreaking stories. So it was very humbling. But what it really made you think was if people would just see people as people, how different this world would be. So I think that even applies here. Okay, so back to the thing. So I thought we'd start with the myeloma, because this part I've done in much more depth. And then afterwards, I'm really just going to skim around some practical things for people who are actually working in practice. So myeloma is a I think probably what we see the most of, and now my thing. So just, this is a thing you've all seen, the whole paradigm of relapsing disease and how you treat it, but just to highlight the whole initial therapy of myeloma, there's no question anymore. It's induction, consolidation, and maintenance with a stem cell transplant in there if you can, and if you can't, you just keep going with continuous therapy. So this treating people and then letting them go after their transplant is not on anymore. That's how we're supposed to treat people. And we've got more and more drugs, and they all start here in the refractory thing and start to move up. But the way we can treat is so totally different now. And I just want to talk a little bit about the sort of end-line relapse refractory, and then I'm going to talk a little bit about what's coming up in the beginning. Firstly, I have to acknowledge these slides, some stolen from Prof. Moti, some out of my head, some stolen from Shaji Kumar's lectures. So they all come from all over the place. But I thought this was a really good illustration, actually from blood. It's an old thing, but it just shows you when you start with myeloma, you have a whole lot of different subclones. And when you start treating, you start selecting out different clones. And what you end up eventually is this one really, really lethal clone. So that's why you can't just treat and stop, because you accelerate this process. You've got to try and treat and sit on it and stop this process from going. And you'll see that's what's coming with all the stuff presented at ASH was about more and more and more upfront. I thought this is very relevant to us. What does refractoriness mean? Because we need to know when do we have to change therapy. So refractory myeloma is either not responsive while on the treatment, or it progresses within 60 days of the last therapy. That's important because sometimes we kind of stop treatment, see them progress, and then go back to the same treatment. It's not the right thing to do. And non-responsive disease is just not showing anything. Stable disease is response, and we definitely see that. Some patients slowly respond, get to a point and nothing changes, but that's still a response. And obviously, you can be primary refractory, you can get refractory at a later stage. This is a really relevant slide for the clinicians among you. So refractory is probably dose independent. And what they're really showing here is whether you refractory to low dose or standard dose, you just don't do as well as if you're not refractory. So changing up the dose is not going to change your outcome. So really just showing you that. And I think that's very important. So we often have patients on lenalidomide maintenance and we consider just increasing the dose. If they're on lenalidomide maintenance and they progress, they are probably refractory to IMiDs, which puts them in a rather desperate place. Once you're refractory to IMiDs, bortezomib, and antibodies, and would that we had the option to have many patients like this, because a lot of our patients never see the anti-CD38 antibodies, you become what we call triple class refractory. And there's a sort of progression where that's a standard procedure. If you're exposed to the drugs, and we don't get there, we have a bit of a skewed version of this because we don't use these monoclonal antibodies up front. But once you become triple refractory, the progression-free survival, especially in high-risk disease, is dismal, about 4 months, and the overall survival a year. So this is a really poor group of patients, and the median time to get to there is about 3 years. Higher for the high-risk patients in the standard risk. So you're going to get there if you have access to all these drugs, and you really need to see where do you go from there. And there's this just plethora of different drugs coming out, just to show you what is actually out there. And a lot of this was talked about and presented. But I like this. It's just kind of a tail down of those. So what are your options? I think a lot of us won't be dealing with triple refractory disease because we haven't got that luxury. But even in our setting, what can you do? So recycling, that's what we do. That's the South African version of approach to this. Look at next generation drugs. If you're on lenalidomide, maybe you can use pomalidomide. If you're on Velcade, make an upgrade. Look at new combinations. It really does work. And don't underestimate this. And I'll show you one that came out in ASH that is really quite relevant to us. And then there's always these small molecules that keep coming up for them. Cell mods, they've been around for a while, but now suddenly they're becoming more important. And essentially what they are is the next version of the IMiDs. So you've sort of got thalidomide, lenalidomide, pomalidomide. Now we're getting to the cell mods, and some of them are quite exciting. But most of the things in this group, when they cause a response, it's sort of progression-free survival of about 3 months and about a sort of 6 to 9 month survival. So in themselves, they're not strong. And if ASH has a name in terms of myeloma, it was #immune modulation. That was what it was all about. And then I thought this, just before we get to that, I was saying that recycling is where we should go. This is a regimen and a study that was presented that I think is actually relevant to us. Probably more relevant to those in private practice than those in state. But this is a study looking at isatuximab, which is an anti-CD38 antibody, so like daratumumab, with carfilzomib, which is a second-generation proteasome inhibitor, and dexamethasone, and comparing it to carfilzomib and dexamethasone. That is obtainable therapy on higher plans in private practice. And essentially, and they talked about it, it doesn't have to be isatuximab, which is coming in South Africa, but we don't have, but it's probably a class effect. So essentially we're saying if you can put an anti-CD38 antibody with a second generation proteasome inhibitor, even in early relapse, which is poor prognostic disease, you get a very significant response, and the progression-free survival can be up to 2 years. That's a huge response in a relapsed patient who's, especially if they are triple class refractory, but even the ones we see when we run out of options, this is something, it's a low hanging fruit. I know high if you don't have these drugs, but definitely obtainable for some of our patients and something not to forget. So you don't have to have access to all the fancy immunotherapies. This stuff is still expensive, but it's a little bit more attainable. I loved this illustration. So the target for most of the immunotherapy after the anti-CD38 antibodies, which was the start of it, is BCMA. BCMA is on late memory B cells, and it plays a role in long-lived plasma cells, the survival of them. So the reason this is appealing is that may give you some sort of access to a myeloma stem cell. That's why it's important. And that's why they've targeted it. And that's why it's effective. The way we go after BCMA has changed. So there was the antibody drug conjugate. So that was belantamab mafodotin was a sort of prototype of it, which was an anti-BCMA antibody linked to a payload of a drug, which would be lethal for the drugs. And unfortunately, that one's been withdrawn. I think Andrew mentioned that last week. There's just bispecific antibodies that connect T cells. They haven't really gone far. And then we have the bispecific T cell engagers. This was the buzzword at ASH. This is what Andrew spoke about last time. And in the context of myeloma, it's T cell engagers that connect the T cells to BCMA initially, but there are a whole lot more of them now, and CAR T. I'm not going to go into that because this lecture is supposed to be about what's obtainable to us, but I think that this really does bear looking at. So the CAR T, the approaches of immunotherapy, which is where it's all going, is you're going to use your immune system to get to your myeloma. And the two sort of remaining methods that we still have, or the ones that are the winner methods, are CAR-T and bispecific antibodies. So the first thing that needs to be said is the efficacy is probably about equivalent. What's important to note here is that CAR-T in myeloma is not curative therapy. When we talk about it in diffuse large B-cell lymphoma and sometimes in the lymphoblastic leukemias, that's what we're aiming at, curative therapy. CAR-T cell in myeloma is just another modality of therapy, and you need to bear that in mind with all the problems related to it, particularly in terms of cost and that. So CAR-T cells and bispecific antibodies, similar order of efficacy. Durability of response is really good because everything else, by the time you get these multiply refractory patients, it's sort of, as a rule of thumb, 3 months, if you're doing an exam, 3 months progression-free survival and 9 months overall survival. This is very different. But CAR-T is very limited. They talked a lot at ASH about slots and people queuing up for these things. You have to have a specific facility. There's a 4 to 6 week turnaround time. And essentially, the patient has to be able to come off treatment for that period. I've had patients who I was trying to get to CAR-T, and we just couldn't because we couldn't keep him off long enough to get the T-cell levels to go up. If you've been treating them before, you drop, especially your CD4 cell levels in the myeloma patients, and you just can't get there. Whereas the bispecifics off the shelf, they're wider availability. And so there's much more access to them realistically. It's not a one-time therapy, it's ongoing therapy. And it's very doable, less cytopenias. A big thing with the bispecifics, though, is infection, because you get T-cell exhaustion, essentially. With the CAR-T, you modify the T-cells, you put them in, and those T-cells maintain it. With bispecifics, you keep harvesting new T-cells to react to your stem cells, and you actually get exhaustion. So you have to watch infection, and that's been definitely a signal with these bispecifics. But this then is really the telling thing. So look at the price. And this is realistic. A CAR-T cell, $400,000. So multiplied by 20. Massive cost to CAR-T cell therapy. Bispecific antibodies, less, although you have to stay on them. So since you stay on them for long periods, they very quickly catch up. But essentially, this was Shaji Kumar. He was postulating CAR-Ts will be out and bispecifics in the setting of myeloma. And I think that is probably true because, as we said, it's not curative therapy here. It's a modality of therapy. And then the recycling, don't forget that he likes selinexor, so that's why it appears here. But that thing, like I talked about, the daratumumab the isatuximab with the carfilzomib, still really expensive, but a little bit more time limited. So that's just worth thinking about. And then again, Andrew talked about this in other contexts, but it's quite helpful just to mention it in the context of myeloma. So the bispecific antibodies, it sounds pie in the sky for us and very far away. Fortunately, it looks like missing out on CAR-T might not be the worst. Bispecific antibodies are actually around the corner. Janssen has got teclistamab, and hopefully we're going to see it here. Most of them originally targeted at BCMA. The benchmark response rate is around about 70%. So really, really good response rates, overall response rates around about 70%. And this is the thing that's incredible, is the duration of response. The problem is you have to stay on the drugs, but there is nothing in this setting of relapsed refractory disease that can give you these kind of durations of response. And the patients do really well on them, given the infection risk. And what's exciting about them, there's more of them coming out. It's kind of a Me Too thing. But when one target doesn't work, now they've got a new target. And this talquetamab, I had a patient who was going to get onto a trial of that in Germany. It's there. So there's really good options. So I think this is just really just to show you, not to say use selinexor, but this is the standard for most other therapies. Progression-free survival, 3.7 months, overall survival, 8.6 months. And if you look at this progression-free survival, we're talking 18 months. It's in a ballpark of its own. More expensive, but not that much. So bispecific antibodies in myeloma, just really to press that, because that was really the gist of lots of the stuff at ASH. We spoiled for choice. They are effective in heavily pretreated patients. The overall response rate's around about 70% with prolonged duration of response. You can probably use them serially. That's pie in the sky for us. and it is possible to stop and retreat. Infection's a problem due to T-cell exhaustion. And everything says use them earlier, use them quicker. So this is just a thing, just where they're going. Now they're putting them up front with daratumumab and lenalidomide. The cost of this is scary, but that's where it's all going. So that was sort of relapse refractory myeloma, just all heading towards immunotherapy. And then what about frontline therapy? So again, this one's just a whistle-stop tour, but this is where there's stuff that's relevant to us. So they talked a little bit about the Griffin trial, which is Dara-VRd versus VRd, talked about depths of response and genetics. They very much, it was a case of in high-risk disease, you put a whole lot of stuff together in the beginning, and then in transplant ineligible patients, Maya is the big news. And I'll show you they had what they presented was the 5-year trials on Maya, which is Dara, Lendex versus Lendex alone in older patients. And really the results are quite phenomenal. So this is the Griffin study, it was frontline treatment in transplant eligible patients getting Dara-VRd versus VRd, followed by stem cell transplant, and then some consolidation and then maintenance. And remember, we said that is now the standard of care, first line. Doesn't matter if you're starting with SIBOD, stem cell transplant, you must consolidate and you must do some kind of maintenance, even if it's Velcade every 2 weeks. So just to point out here some interesting things. So there's a whole debate about what is lenalidomide maintenance. In this trial, they started with 10 milligrams, day 1 to 21 in maintenance. And then after a few cycles went up to 15 milligrams, day 1 to 21. The original trials showing overall survival advantage on lenalidomide maintenance actually were with 10 milligrams daily, but I think this gives some guidance as to how to use maintenance. So maybe not at the lowest dose of 10 milligrams day 1 to 21, either a bigger dose, day 1 to 21, or low dose longer term, sort of for 28 days. And the Dara maintenance, what's interesting here is they said either every 4 weeks or every 8 weeks. Obviously, that's very relevant, both from a cost point of view and to your patient. So that's just an aside. But this was the Griffin study. And even before, because this is upfront good therapy, there was not a huge difference in the progression-free survival wasn't reached in either group at sort of 15 months. But there is still already a very big difference. And what they showed now at ASH, this was before, is that is prolonging out. But what was a big thing at ASH now was talking about the depth of response. We've all known about that. We've seen it before. It came up with ixazomib. It comes up in this Griffin study. Even if you look before transplant, so this is looking at if you get a VGPR after induction, that's before you've transplanted your patient, you do better than if you don't. And if you get to MRD negativity with Dara RVD after transplant, you just about get a flat line. So there's phenomenal response if you get the depth of response. If you don't get the depth of response, you still do well, but you drop off. And I think what's really interesting about this is it's telling us that MRD does not equal MRD. If you get MRD negativity on the lenalidomide arm without the Dara, they don't do as well as those that they did. So just tells us that we don't know what MRD exactly is, or we probably can't test deeply enough. But so the message here is really depth of response is important, but how you get there probably also matters. And the other thing they looked at is subgroup analysis on these regimens. And we talk about high risk as patients with one high-risk chromosomal abnormality. Dara overcomes that completely. Lenalidomide not. So just if you leave out the lenalidomide and use what we call VRd or they call RVD, they do okay with no high-risk abnormalities. But if they have high-risk abnormalities on the len, they don't do well. If you have more than one high-risk abnormality, so 2, they call that ultra high risk. Even with Dara, you can't really salvage those patients, therefore. And just, I thought this was really important, so I put it in. Chromosome 1 abnormalities, we didn't even test for them a few years ago, but they are turning out to be really nasty. And I must say that's been my experience. Patients with chromosome 1 abnormalities, either 1q deletion, 1p deletion, they really are, and all amplifications of 1Q. They are bad news. So not going to go into this at all, but essentially what they're now doing is they're taking out these, what they call ultra high risk patients, and then they just treat them to death. And this is, sorry, to life, treat them to life. So this is the Optimum study. And this is the UK, conservative old UK, where they're taking these ultra high risk patients. And I don't think the details in that are that serious, but it's just to point out, starting off with 6 drugs, DARA, cyclophosphamide, VRD, and then they transplant them, and then they carry on with the DARA VRD, and then go down to DARA V, and then just go on with DARA-Rs maintenance. And this is in the UK. And they compared a digital comparisons just because they were comparing to how they previously used to treat their ultra high risk patients. And you can see that with this massive, really massive therapy, and it's shades of, I don't know how many of you are old enough to remember or have ever heard of total therapy, but originally when they were trying to handle myeloma without the fancy drugs, there was a group in Arkansas, and they would just treat these patients cycle after cycle. And they did actually cure some of them and keep some of them alive. And we're going back to that the only way to go after these high-risk patients is with ongoing intensive therapy. And this is just a German study actually doing exactly the same thing. Here they were using isatuximab, not DARA, with carfilzomib and Lendex, transplanting them, giving them consolidation, and going on 26 cycles of isatuximab, carfilzomib, and lenalidomide. It's huge, especially since you could, by the way, carfilzomib ideally twice a week IV, and they would be going on for years like this, but it actually worked. So really just the message and not the detail is that across everyone's looking at more and more intensive therapy for the really high-risk patients. And that just really just showing that it works. And then the one thing, so that's all a bit pie in the sky for us, but I think the one thing that we really need to look at is MAIA. So MAIA is frontline treatment of transplant ineligible patients with DARA RD versus RD. It's not new, the trial's not new, but what they did present was then the extension studies. So the updated analysis, which is what was presented at ASH, showing that up to 6 years, at 6 years, the progression-free survival was still about 50% just with the DARA, and about half of that with RD, although Lendex is a good regimen. And the overall survival at 6 years in a transplant ineligible patient is still nearly 2/3 of the patient is still alive. And that really is quite something. And that really essentially is the go-to regimen. And what was probably important here, the same story they keep going on now about depth of response, MRD negativity counts, and again showing you that if you get your MRD negativity using DARA versus not using DARA is slightly different, and that you could use it across all age groups. So this was showing you in a group of older than 75-year-old patients, they're still getting the same sort of responses, and 75% overall survival really at 6 years, quite phenomenal in those older patients. But I think this was the slide which caused the most interest. And this is looking at quality of life. And it was showing that on treatment, older patients' quality of life was actually preserved quite well, especially with the DARA arm. What is concerning is over time there is a loss of cognitive and social functioning, whether that's a function of age or not, but in terms of energy and fatigue and etc., it was good. So really what they're saying with these trials is DARA RD is really the treatment of choice for older patients. RD, from our point of view, is an incredibly effective regimen. It's probably where we should be going, leaving the VMPs and other things for subsequent lines, and that there is quality of life associated with ongoing treatment for older patients, and that's where we should be going. So since they're looking at quality of life, this is just, I thought this was really funny, but the next thing they looked at is, well, the thing that causes the most lack of quality of life in older patients is the steroids. So can't we leave out the steroids? And the answer is, yes, you actually can, and they do better, but I don't think that we're ever going to be going with lenalidomide and subcutaneous DARA as a nice, easy option for older patients. So it's an interesting choice. And then this one I put in because I think it's very important. It was lenalidomide maintenance. How long do you go on with maintenance? And there's always discussion. And I think it's kind of been answered before, but this puts it so graphically. So this is looking at the trials across the globe. So The American trials, they would get RVD, and then if they could get transplants, they'd get transplants. If they couldn't, they just got more cycles. And then they went on to lenalidomide maintenance until progression. While the French trials, the sort of European side of things, was to same thing, same process, RVD, carry on without maintenance, without transplant if they can't, with transplant if they can, but now they limited the maintenance. And although we're comparing across trials, if you look at the progression-free survival on the two trials, which are essentially the same up to the point that they stopped maintenance after 1 year here, you can see that the progression-free survival is so much better. So it was kind of agreed that now, if you're on maintenance, Len, you just continue until progression. That question is very clearly answered. So, breath from that, and that's kind of the most sort of in-depth stuff I want to do. And then now this is the ash in a flash bit, because I just want to, and you know what, I gave up trying to find beautiful illustration slides. So this is just facts that I learned sitting at these lectures that really have helped me, and everything I'm going to talk to you about, I've started using since I've come back. So really helpful sort of stuff. So firstly, AML, and I went to an educational session on AML. It's very MD Anderson twisted, because they're the ones who kind of very much leading in the field. But I think for me, it clarified in my head, what is the role for venetoclax in the setting of AML? So the whole thing of adding venetoclax to high-dose chemotherapy, and they do high-dose cytarabine, and clear is their cladribine, and intermediate dose cytarabine with venetoclax, is that they do it in high-risk patients to get them to remission, to get them quickly to transplant. And that's quite appealing. Instead of hammering away at your patients, if you can get them, they literally do 2 cycles into a transplant if they get them here. It works very much for the high-risk patients, even maybe the P53, that's what they were looking at patients. And how do you do it? You've got to only do, it's very, very immunosuppressive. So you only do 1 week, days 2 to 8 of the venetoclax with the high-dose regimens. And you do it with full prophylaxis. So antiviral, antifungal, antibacterial prophylaxis. So cyclophosphoconazole, Perbac, all go with the growth factor support, isolation. And the bottom line is it really works. And I actually came back and I had a patient who I was hoping to get transplanted. I hope you're listening, Cape Townians. I tried to scare. And then he's a young guy and he had terrible, terrible cytogenetics. He failed the standard induction and high-dose cytarabine. We had him on Vidase venetoclax and he was doing very well, and we hoped we'd get him to a haplotransplant. And then he started to progress on the Vidase venetoclax. And I came back and we talked about it, and we gave him 1 cycle of this, and he's really gone into remission. He has 0.2% cells on flow, so we're going to give him 1 more cycle. But this is very effective, but it is very toxic. You have to be careful with it. And another thing, which is very practical for us and very usable. So we all know the trial from the Viali A and the Viali C studies, where they put venetoclax with firstly Vidase in the Viali, with azacitidine in the Viali A trial, and they showed really excellent responses in patients with AML who couldn't get to high-dose therapy. And then they had the VLSC trial, which was against low-dose with LODAC, venetoclax with LODAC, low-dose cytarabine. And definitely in those trials, VLA-A with azacitidine is better than VLSC with LODAC. But what they're doing, and this is an MD Anderson thing, taking patients as ineligible for high-dose chemotherapy AML, so older AMLs or ineligible for high-dose chemo, and alternating LODAC, which is cheap. We can give it to your patients. Venetoclax isn't so cheap, but you can, by ways of adjusting the biokinetics, make it affordable. And cladribine, and put them alternating with azacitidine and venetoclax. And the response rates are absolutely phenomenal. So in patients, they had patients over 60. It was only, I think, 60 patients on the trial, but half of them had horrendous genetics, and they got 84% MRD negativity here. Really incredible results with a actually affordable regimen, the venetoclax excused. So it's really something to look at. And again, I've had a patient who I had on Vidase venetoclax, who he was a PVR which had progressed to an AML. And I've put him now onto this low-DAC venetoclax cladribine. He's had an amazing response. So it's just a regimen those of us who have access to a little bit of these drugs can actually maybe think about in patients when you're struggling. And then a little bit about CLL. So CLL, for me, the big question, and I know again we're privileged in private practice to be considering whether we want to use venetoclax or obinutuzumab versus ibrutinib first line. So old ways used to be chemotherapy. There really should not be a place for chemotherapy except perhaps in a small group of younger patients with good prognostic features who may be cured by chemotherapy. And even that one's debatable. But standard of care now is venetoclax with obinutuzumab versus a BTK inhibitor like ibrutinib. And the question has always been, which one do you go for? So I've always favored the venetoclax with the anti-CD20 arm because it's time-limited therapy, but had this feeling at the back of my mind that maybe we should be using the ibrutinib more for the P53s. And this was really helpful stuff. So basically, it tells you with either regimen, you get about a 75% progression-free survival at 4 years. So they're both really good treatments to choose. Because you're only using venetoclax or obinutuzumab for a year, because it's 6 months of obinutuzumab and a year of venetoclax, there's less pressure to resistance, lower costs, lower side effects, and you can retreat. That's an important point. So there's very limited data that actually does favor the Bruton's tyrosine kinase inhibitors, that's the ibrutinib, versus Ven-O in the P53 patients. Those are your very worst prognostic patients. And we kind of felt that you should probably use ibrutinib because it's continuous therapy. And what they showed was that you get a slightly longer progression-free survival with ibrutinib, 5 to 6 years versus the 4 to 5 years with venetoclax. But you can then go back and retreat. So there's really no indication that would favor you necessarily using the BTK inhibitors there. So what makes you choose which ones? Quite a relevant fact that they said significant numbers of patients with ibrutinib do develop hypertension and adverse cardiac events. They quoted 70%. I shouldn't have probably written this down on the slide because I need to find where that came from and I can't tell you, but that was what was said in the lecture. Toxicity increases with age, just a bit of practicality, because we often see these patients and get asked, what do we do about them when they're going for procedures? So there is a risk of bleeding with ibrutinib. So you just need to stop for about 3 to 7 days. And definitely the risk of bleeding is relevant. So they shouldn't be patients with vascular disease on dual antiplatelet therapy. There's a lot about the alternative Bruton tyrosine kinase inhibitors, and they're not really relevant to us because we haven't got access to them, but they're coming. And essentially, acalabrutinib is equivalent to ibrutinib, and zanubrutinib probably looks like the most efficacious, and both of those are less toxic. So I think ibrutinib in this context is going to slowly fade out. Venetoclax has a problem in patients with bulky lymph nodes. This is really meant to be practical stuff for those who are treating patients. So hopefully not losing too many of you here. You have to be careful with previous cytopenias. It is immunosuppressive a little bit. This is really important. They have real concerns about tumor lysis. I've always been quite blasé about it because I feel we see tumor lysis, we know how to treat it. In fact, I don't know if any of you have ever used venetoclax with obinutuzumab, but you start with the obinutuzumab. Within 3 days, the entire lymphocyte population seems to disappear. So that by the time you get to the venetoclax, you don't really have to worry because it's all happened already. So if you can keep your patient around in the beginning, the first week we see them every few days, measure their UNE, uric acid, make sure they're getting enough fluids. And on the regimens, they start with obinutuzumab and they only start with the venetoclax on day 22 of that cycle. So we haven't been worried about it, but there really is a concern. They say, even in patients whose counts look normal, they're seeing this. So the comment very much there is if the patient lives far away, that would be a reason to consider ibrutinib, as opposed to we think, well, they just need to stay around for the first week and they're fine, or first few weeks. So just maybe for me, a new respect for the whole tumor lysis thing, just to be aware it's not just gone when the counts are normal. And then another just practical question when you're using venetoclax here, I was sort of wondering, I had patients who hate using Pervac and wanted to know, one of them is a doctor, so of course he looks it all up. We started monitoring CD4 counts, and you'll see they don't actually drop that much on the venetoclax obinutuzumab. So they specifically say that you don't need PCP prophylaxis in first-line treatment. Maybe in relapse, they should all be on antiviral treatment. So I think that's just really useful, practical stuff. And then the last thing was, we always have to use venetoclax with obinutuzumab first line, and in relapse patients, venetoclax with rituximab, because that's how the trials were done. And I always think that makes no sense, because the second line patients have already been exposed to rituximab when they got chemotherapy with rituximab. And they have this Gaia trial where they have arms with venetoclax obinutuzumab and venetoclax with ibrutinib and obinutuzumab, and then venetoclax with rituximab, and just shows that the obinutuzumab does make a difference. So it's worth fighting for your patients, and I've done it a few times second line to say to medicals, look, they've already had rituximab, can we use the obinutuzumab? The reason we don't use it in the trials is just how the trial's done, and they have agreed, and it does seem to make sense to go that route. And then just another interesting trial presented, which I thought was really relevant, because we keep saying that maybe the combination of venetoclax with ibrutinib is the way to go, the combination of the two. And they actually had presented the CLL-17 trial where they compared venetoclax ibrutinib with venetoclax obinutuzumab, and in fact, it's equivalent progression-free survival. So the final and prolonged results of that trial are not out. That's not a final comment, but maybe the combination is not essentially what we are aiming at. So just an interesting thought there. And then what happens if you're lucky enough? And again, I realize we're in a luxurious position that we can actually find this thing out. If patients are refractory to both. So I have a young patient. She's a really sweet lady, works on the mines. She sorts platinum and she loves it. And she had bulky CLL at the age of 35. We started her on venetoclax obinutuzumab. And after an excellent response, she ended up progressing very quickly within the first year. Then gave her ibrutinib. And once again, same thing happened. And she progressed on it. And then kind of thinking, well, where do we go now? So it's worth knowing that resistance to ibrutinib is due to a specific acquired mutation. There is a particular mutation, but there are a few. And venetoclax resistance is due to upregulated apoptosis pathways. So for double refractory patients, if you have the luxury, there is a different kind of tyrosine kinase inhibitor, the non-covalent BTKs, and they work with the resistance to the specific mutation that's common. CAR-Ts, obviously, bispecific antibodies, obviously, but none of that's really realistic because we can't get any of it. But what is maybe realistic is that the resistance mutations, both of these different things, usually happen in different subclones. So you can use combinations. So you can actually take your patient who's resistant to apparently both of them, put them together, and you can use that as a bridge to transplant. And that's exactly what I'm doing. And that's why I found this ASH so useful. It really does give you direction of what you can do now. So, and the medical aids, by the way, for those who are having to deal with them, that's a magic phrase, bridge to transplant. It does open many doors. I don't want to commit to long-term anything, but if you want to use something like this as a bridge, they often would look at it. And then amazingly, low-dose lenalidomide, probably with anti-CD20 antibody, but can have some effect. And I was hoping Vernon would be here, because long ago we used to talk about using high-dose methylprednisone with rituximab in these patients as a bridge to transplant, and maybe that's worth looking at again. So what do we do in South Africa with these patients? See if we can get the two together for a short period, and then maybe look at lenalidomide, which is in our setting quite cheap. And then I picked out Richter's because, again, I had a patient who this has really helped me with. So Richter's transformation is transformation of CLL to a high-grade lymphoma. And it's not that uncommon. when you think how commonly we see CLLs, and I've certainly seen a good handful of them in the last few years, and I'm sure you see them a lot also in state. Now, most of them get diffuse large B-cell lymphoma, but they can become Hodgkin's, interesting, or other lymphomas. And I thought that was quite sobering, because I've kind of always thought, oh, well, you just treat them with CHOP and then manage, but only less than 20% get a CR rate, and there's very poor overall survival. So the aim is really to get them into CR. And then we always think of allogeneic transplant, but what they were saying here was, as long as if it's clonally unrelated, so if you've got two separate clones, you don't have to do that. You treat the diffuse large B-cell lymphoma and then the CLL perhaps on its merits. And if it's previously untreated, and that was my patient at the time, so he presented with a mass in his abdomen and sort of blast-like things in the peripheral blood, but had an underlying CLL with transformation. If it's previously untreated and diagnosed at the same time, they actually can do well without a transplant, as long as there's no P53 mutation. And they spoke of combining our CHOP or our EPOC with venetoclax, and there's a really good reference there, you'll see that. And that's what my patient had been on our CHOP, or in fact our EPOC, because while I went, she started on that, and when I came back, he hadn't responded very well. So we've added the venetoclax, and hopefully we're going to get there. Interestingly enough, CAR T cells don't really work here, and then you get these wonderfully expensive combinations. Not sure, I'll just do this as the last thing. I think there's probably like a way overload of information here. And I mean, I could talk to you about so much. It was really an amazing meeting. They're talking about now the cytopenic myelofibrosis and all sorts of things. There's so much stuff here. But just one that we probably see a lot of is diffuse large B-cell lymphoma. And I thought what was really helpful was an overview of it and saying, you know, we know all these things and these fancy genetics and GCBs and ABCs and so on. But when do you actually treat someone with diffuse large B-cell lymphoma differently as opposed to just basic R-CHOP? And the whole thing of double hit lymphoma was very clarified. So we always talk about MYC BCL2 and BCL6 rearrangements, not overexpression, but actual rearrangements on FISH as double and triple hit. But apparently MYC BCL6 is not really specific for double hit. You can actually find it in some of the GCB better prognostic lymphomas. In itself, not an indication to change your treatment. Double expressor is not you, so that's when they overexpress MYC BCL2 and BCL6, but they haven't got the actual rearranged genes. It's not unique biology, and they don't necessarily do better with different treatments. They're still high risk, but they don't necessarily. So it's really only the true double hits, MYC BCL2, that needs to be considered for different treatment. So instead of just R-CHOP, how do you treat them differently? That's where the problem lies. It doesn't help to add maintenance. They've done trials. They showed trials. There's no help to adding biologicals. Lenalidomide, ibrutinib, infusional therapy probably does work. So our hyper-CVAD, RMAs, or our EPOC may be better slightly than that, but it's difficult. And then polatuzumab, it's here, it's available in South Africa. We've all kind of looked at the studies first line. The 2-year progression-free survival is 76% versus 70%, and you kind of wonder if that's relevant. But what I thought was a good way of showing it probably is that it prevents 1 in 4 relapses. So for your high-risk patients, your ABC patients, high-risk patients, probably is worth fighting for. Interestingly enough, in the true double hits, it doesn't help. So polatuzumab, we should be maybe trying to get first line for the high-risk patients, because it probably will prevent a significant number of them from progressing. What was new in terms of first line, there's all the unobtainables, tafasitamab is another anti-CD20, and of course bispecific antibodies, and of course CAR T cells. They're doing a trial of a CAR T versus a dose-adjusted R-EPOC first line. But something we need to remember is ibrutinib with R-CHOP in younger patients. And they showed a trial which showed improved survival, and that is worth trying. I have a patient with not quite the same setting, but a Burkitt's who got R-CHOP first, and then when he came to us, we tried RMA, hyper-CVAD, and he's not responding, and we've added ibrutinib, and hopefully he does seem at last to be responding. And then for relapse, also, there's a whole lot of unobtainables, these fancy bispecifics, and tafasitamab is the anti-CD19 and lenacapavir. But polatuzumab with bendamustine is something that, once again, would probably be worth fighting for and trying to get for your patients here. You can get it if you have the luxury in private for a few cycles before getting to transplant, and that would be a really useful thing to try and get. So essentially, I think ASH is a bit like a box of chocolates. You can open it and you can like eat all the chocolates, and you're going to end up like this. So I think you can't do it. You need to go through it a little bit. To go to a meeting like that, there's different ways. There's all the exciting new science, and a lot of that is not obtainable, and sometimes you do kind of switch off it, but there's also a lot of it that's really, really realistic, and can change your treatment. And I hope I've highlighted a little bit of that, not just where we're going, but some practical things, and there was a whole lot more. So yeah, just a big thank you to Janssen for sponsoring me to go there. I think it was really, for me, probably one of the best meetings I've been to. And thank you very much for the chance to talk about it and share about it here on Deep Dive. I'm going to end there, hopefully, stop share, and see if I can look at any questions.
I think there must be some questions. This was wonderful, and you know when to stop, because you leave us wanting more.
I hope so. Not like a lot.
We want some more chocolate, so let's see what the questions are. You've got so many colleagues here who I'm sure want to ask questions.
So there's a comment from David. He's usually, would be first line. He gives the venetoclax starter pack. So you start at 20 milligrams, then 50 milligrams, and 100 milligrams, build up slowly, and then add the obinutuzumab with full dose venetoclax. And absolutely, that makes so much more sense to me. It was just really interesting that is not at all done. I asked them about that, and I said to them, do you see this? And they said, oh, yes, but they don't do it. And they all say, because they're so scared of this tumor lysis thing, that you must start with the monoclonal antibody. And I said, but why? You see this? And they say it's not necessarily, it goes back to the thing about the levels of the counts, and that's just a sort of almost something that you've got to be careful of with venetoclax, regardless of what you think you've already achieved. Yeah, and I agree with David. We often see some tumor lysis, but what we do actually is when we start treatment, we see them on the third day and give them some extra fluids, check their urinase and that. So you just got to be proactive, and of course everyone needs allopurinol. Estelle said, yeah, she's actually answering that thing. You prefer not to control counts with abinutuzumab. That's the overseas thing. I kind of half them on David's side, because abinutuzumab's a scary drug when you see that. And thanks, Jasmine, for your comment, and Justin.
I'm going to be very practical, because there's people who really want practical, because we don't use it. So is it when the counts are very high that the abinutuzumab is so dangerous?
So I think taking cognizance of what they told me at ASH, I think I still would start with the monoclonal antibodies. That really is the feeling overseas, that we should start with it. But be aware, if you start a new patient with CLL on a monoclonal antibody like obinutuzumab, you must see them within a day or 2 days, 3 days, and give them extra fluid and watch it and manage it first, and then do the venetoclax ramp up once you've really done the site reduction. And when you start the venetoclax ramp up, still be careful. Don't assume there's no risk now because the blood counts have gone back to normal. That was really, and again and again it was said, it seems strange to me, but it was said by more than one people in more than one lecture, that just because you've got your initial site reduction with your monoclonal and anti-CD20s, you can still get tumor lysis when you start on the venetoclax.
Let's see which quick. Does anybody have more questions? Oh, there's one from Andrew.
Yeah, so Andrew's commenting on that trial with the polatuzumab up front. And exactly, I felt the same as him. You know, it's a progression-free survival, 74% versus 70% is not that relevant, but it really is about the relapse risk. And it is hard to sell it to the medical aides, but wow, you know, that's quite a game changer. So I think for our very high risk patients, we need to maybe push on that, because 1 in 4 reduction in relapses is really impressive.
I was just wondering if any of the private colleagues, because I don't think any of us in state have done it, would have used sort of something approaching these alternating. I think it was from Korea. I think was the paper, the alternating low dose RSC, venetoclax, cladribine, AZA, this alternating scheme for older patients with AML, or for, is that something that has been sort of unofficially done? Is that, you know,
I've started that in private, but I wonder, do you have access to venetoclax in state?
no, only when we get a really big, yeah, no, actually not. We have used it, but very, very, very limited. And I think, I don't know, Vanitha and other colleagues at, I see Fatima, yeah, it's not something we actually have access to.
It's just interesting, you know, the whole concept. And so this is an MD Anderson thing, that there's something about venetoclax LODAC, which is not what the Viale trials showed, but they say they think there is something in there, and especially when you add the cladribine.
So,
do you know the cost of venetoclax, if you use 100 milligrams a day, and you'd have to use it with fluconazole there, is about 30,000 Rand a month. So, I mean, that is a lot, but when you know, look at actually the cost of any chemotherapy regimen, we're talking in that ballpark. So, it's just worth knowing that.
That's, I think, a paradigm shift, isn't it? You know, where the cost sits. And I hope we can understand that better, because there's different sort of silos of cost, and we must decide what is the best way to divide this cost. So from our side, there's definitely the thinking, which we cannot put into practice yet, that alternative agents, novel agents, could actually replace some of the chemo drugs. And what I find interesting from this is that they're now paired. And that's actually interesting, Karen. So there's a pairing of cladribine, RSC with novel drugs. And I think that's interesting.
That thing of high dose cytarabine, or nobody uses high dose anymore, but that's sort of intermediate, so full dose cytarabine with venetoclax, maybe that's very relevant to state. If you could cut down cycles of chemo and get patients into remission quickly and to transplant quickly, it would maybe be a very relevant cost-saving thing, but very toxic. So I don't know if that is safe in the state.
Yeah. Are there other questions? I think from my side, Karen, I can just say that you're welcome to come back next week and tell us more. Do you have some more? I think everybody would say,
right. There is actually so much, but yeah, just the practical stuff. It was amazing.
No, thanks. And it was really, really lovely. I think, are there other, Jock has also a remark.
I mean, looking at the cost of venetoclax with fluconazole around 30,000 per month. I mean, we've got a few patients with CML that we've got sort of motivated for dasatinib in state, which is roughly, I mean, it still costs around 30. So, I mean, one could argue that at that cost for the specific patients, the challenge is going to be, it's going to have to be limited to patients where, so I think that's going to be the biggest challenge. Which patients do you choose to consider this?
If you think about it, the dasatinib is going to be a continuous therapy for at least 5 years or longer.
Yeah.
And, if it works, obviously, if it's the fit for this patient, but venetoclax and certain combinations of these drugs could actually, it's possible that it can cure. So it's definitely, hopefully my hope is obviously that there will be homegrown data at some stage, because we will look at it differently from the rest of the world. So, I mean, that would be the ideal. I think last week when Andrew and Jacques spoke, there was somebody said very strongly, we should have clinical trials platform that's better, that's set up so that we can do more things together and actually get results that fit for our region. So, Karen, you've made our Monday afternoon, and I think you've let us go early, and but it's with a lot to think about. And everybody, remember that this talk, as the others, will be on the website. Very nice to listen to or look at when you've got a quiet moment. And yeah, we see you next week, and look forward to lots of interesting talks in this year. Thank you. Thank you, Hardin, and thank you, Melanie, and the team supporting us to set this up. So good afternoon, everybody.
Thanks, Estelle.